Hello and welcome. Today, we're diving into the fascinating world of urological anomalies, specifically focusing on ureteral duplication. This condition, while often asymptomatic, can sometimes lead to significant complications. So, let's unravel the mysteries of ureteral duplication anomalies. The exact cause of ureteral duplication is still not fully understood, but it's generally believed to be a developmental issue during embryogenesis. Specifically, it's thought to stem from an abnormality in the ureteric bud, which is a structure that eventually forms the ureter. Instead of developing into a single ureter, this bud either splits prematurely or gives rise to two separate buds. Genetic factors are also suspected to play a role, though specific genes haven't been definitively identified. It's not caused by anything the mother did during pregnancy. It's simply a developmental variation. Ureteral duplication leads to the presence of two ureters draining a single kidney. This can manifest in several ways. In some cases, both ureters drain into the bladder normally, causing no issues. However, in others, one ureter might insert ectopically, meaning it drains into an abnormal location such as the urethra vagina or even the vas deferens in males. This ectopic insertion can lead to vesicoureteral reflux, where urine flows backward from the bladder into the ureter and kidney, increasing the risk of urinary tract infections and kidney damage. Furthermore, a duplicated system can be prone to obstruction if one ureter is narrowed or blocked, causing hydronephrosis, or swelling of the kidney due to a buildup of urine. Ureteral duplication is a relatively common congenital anomaly of the urinary tract, affecting approximately 0.8% of the population. It is more common in females than in males. While it can occur in any ethnic group, studies suggest there may be slight variations in prevalence across different populations. It's often diagnosed incidentally during imaging for other conditions. Many individuals with ureteral duplication remain asymptomatic throughout their lives. However, when symptoms do occur, they can vary depending on the type and severity of the duplication. Common symptoms include recurrent urinary tract infections, especially in females. Urinary incontinence, particularly during the day or night, can also be a sign, especially if one ureter inserts ectopically. Flank pain, abdominal pain, and fever can indicate a kidney infection or obstruction. In some cases, individuals may experience constant dribbling of urine if one ureter drains outside of the bladder's sphincter control. Diagnosis typically involves imaging studies. Ultrasound is often the initial test, particularly in children, to visualize the kidneys and ureters. Voiding cystoscopy of VCUG can detect vesicoureteral reflux. An intravenous pyelogram of EP, which involves injecting a contrast dye into the bloodstream to visualize the urinary tract, can provide detailed images of the ureters and kidneys. In some cases, a CT scan or MRI may be necessary to further evaluate the anatomy and rule out other abnormalities. Cystoscopy, a procedure where a small camera is inserted into the bladder, can help visualize the ureteral orifices and identify any ectopic openings. Ureteral duplication can be classified based on the degree of duplication and the point of insertion. Complete duplication refers to the presence of two completely separate ureters that drain the kidney independently and enter the bladder through separate openings, or one ureter may insert ectopically. Incomplete duplication, also known as a bifid ureter, occurs when the two ureters join before entering the bladder, forming a single ureter distally. The Weigert-Meyer rule states that in complete duplication, the ureter draining the upper pole of the kidney usually inserts ectopically and medially, and is often associated with vesicoureteral reflux, while the ureter draining the lower pole inserts more laterally and is prone to obstruction. Treatment depends on the severity of the condition and the presence of symptoms. In asymptomatic cases, no treatment may be necessary. However, when complications arise, interventions may be required. Antibiotics are used to treat urinary tract infections. Vesicoureteral reflux may require surgical correction, such as ureteral reimplantation, where the ureter is repositioned to prevent backflow. In cases of severe obstruction or non-functioning kidney segments, partial nephrectomy or removal of the affected portion of the kidney may be considered. Endoscopic procedures such as ureteroscopy can be used to correct certain types of obstructions or ectopic insertions. The choice of treatment is individualized based on the specific anatomy and the patient's symptoms. Unfortunately, there is no known way to prevent ureteral duplication, as it is a congenital anomaly that occurs during fetal development. Prenatal ultrasounds can sometimes detect the condition, but this is not always the case. Genetic counseling may be considered if there is a family history of urinary tract abnormalities, although the genetic basis of ureteral duplication is not fully understood. The prognosis for individuals with ureteral duplication is generally good, especially when diagnosed early and managed appropriately. Many individuals remain asymptomatic and require no treatment. Surgical interventions are typically successful in correcting complications such as vesicoureteral reflux and obstruction. Recent research focuses on improving diagnostic techniques, refining surgical approaches, and understanding the genetic factors involved in ureteral duplication. Minimally invasive surgical techniques are also being explored to reduce recovery time and improve outcomes. Further research into the embryological development of the urinary tract may one day lead to a better understanding of the causes and potential prevention strategies for ureteral duplication anomalies. Thank you for watching.